Well, welcome. Tonight, we continue our trek of medical knowledge. We're going to start with a quiz to see if you can actually spell this specialty. We have a local physician who is a GI specialist, and we'll start with an introduction, and then hopefully, while you're Googling, the 6 people who watch will be Googling saying, how do I spell this? But why don't we start with an introduction?
Well, first off, thanks a lot for allowing me to come on and have a chance to outline what a gastroenterologist does, and maybe we can focus a little bit on one of the gastrointestinal diseases. In this case, we had spoken earlier about the possibility of reviewing inflammatory bowel disease and Crohn's disease in particular. So it's an interesting topic. It's one that hits a lot of families in the Milford area, and one which has a lot of hope, and not one that I think people should dread, but they should look at the positives of being able to manage this disease, and it's very interesting and biologically fascinating. In terms of myself, I'm what's considered a general gastroenterologist. That is someone who treats almost all the diseases of the gastrointestinal tract, along with the pancreas and the liver, and that's what we specialize in. As you know, a gastroenterologist is a subspecialty of internal medicine. So most physicians will have trained there 4 years in medical school. I actually had the opportunity to do a little more because I have a doctorate in biochemistry. So, and yes, I used to use a lot of Harvard apparatus equipment in my day.
So you're one of those famous mud fuds, the MD, PhDs.
Yeah, I have accomplished that. That was really a lot of fun, and those who dedicate themselves to basic research are still my heroes, and they were great friends, and they've made a lot of progress in helping. The bench to bedside mentality is one I like to keep active in my career. So seeing what those guys are doing in the lab and applying that to my practice is a very important aspect to medicine in general, and one we respect each other and go forward. But as a gastroenterologist or as a clinician, after medical school, we go for 3 years of internal medicine training, and afterward, we get an opportunity to subspecialize in one of the areas of internal medicine should we decide to focus on one area rather than take on the equally difficult task of being a primary care physician who's trying to treat all of those diseases and orchestrate the care for their patients. So it's a long and somewhat arduous task.
MD, your PhD, your specialization.
Yes, right.
Aren't you about ready to retire?
Yes, then that allows you not to retire, apparently. But it's a wonderful career, and one where you get an opportunity to help people on a daily basis. It's sort of a ministry you can do and at the same time make them feel better, and that's something I think is been a lot of fun, and one we hope we've made some impacts on people's lives as they've gone through.
If you look over the treatment of GI issues in the last decade, it's amazing.
Oh, it's been terrific. I mean, just from acid peptic disease, which is a focus for people who have had problems with reflux, and the management of esophageal disorders, from their motility disorders to reflux, to strictures, to gastrointestinal illnesses, and diagnosing infections that can cause ulceration, through to obviously the big focus these days is on colon cancer prevention. And we spend a great deal of our time, screening and participating in cancer screening programs. I always make this plug because of all of the cancer screening programs, it is really the one that never is questioned as being valid. You've heard a lot about prostate cancer and the issues of whether or not to monitor a PSA and what do you do with the results, and it's just a difficult question.
But when you look at prostate cancer and you say, okay, if we live long enough, They're saying most men would have it.
Absolutely.
And if you're diagnosed with a slow-growing form, you know, by the time you get old and the hair goes white, or in my case, you hope you have any hair, the question comes out, should you treat it? Because
that's right.
It could be 10, 20 years.
Well, that's part of the dilemma of screening for it. It's early detection that, what is the benefit and the risk-benefit ratio. So it's been a very difficult one. It's difficult for physicians to give the guidance they would like because of conflicting data in terms of clinical outcomes. So, but in terms of colon cancer screening, there has been no debate.
I was going to say, we could debate, if I'm 70 years old,
that's right,
and you monitor my progress, and you say in about 20-some years, this could really be a problem. Okay, let's see, actuarially, I'm not going to be around for 20-some more years. But now all of a sudden, mentally, I'm feeling like there's a cancer in me. I can see the physician with this dilemma of,
that's right.
Do I treat or not?
Not only treat, but you want to give everyone their opportunity to make that decision on their own, to give them the information they need, to take a piece of information that concerns them, give them the best guidance you can. Ultimately, it's going to be, with your participation, a joint decision as to how to proceed once you got that either an elevated test score or some abnormality that has been detected. So again, the opportunity to interact with patients and to really impact their lives in both sort of a scientific way as well as as a human being and trying to help them go forward.
I remember almost a decade ago, my mother went in for her normal screening, and we got the phone call that she had intestinal cancer. And when we started talking, they said, she's here. We advise you do the surgery now. And there was never a question as to, well, should I put this off for a while?
Yeah.
And, Mona Kadis was wonderful.
Right. Well,
and I shouldn't say that. She's been
so
supportive. She's been wonderful for my mother. And, part of it is, Mona's in Milford. Right. I didn't have to pack up my 80-year-old mother, drive her to Boston, be it only 20, 30 miles away. It's still not Milford.
Well, we are very, very fortunate to have, not only a cadre of good physicians, and I really have a lot of respect for the medical staff at the Milford Regional Medical Center, but, their affiliations have been outstanding between the Dana-Farber Institute, our UMass affiliations, as well as our Boston affiliations, all of which are just sort of enhancing the care that's delivered to our community. And part of that is because you have people such as Dr. Kadis who form the core of what we have. And, you have places such as UMass or, the Farber who want to be associated with this, these clinicians.
You see the passion when Renee came in, Renee Quantum,
sure,
talked about breast care. You could see the passion she had for taking care of her patients.
Well, that's the kind of thing that, you can only get in a community setting. You can train and work in these big centers. And, I've had the opportunity to work at big centers. I mean, most of my training and work as a doctoral candidate and later as a postdoctoral fellow was at the University of Pittsburgh. And we were doing transplants like mad.
I was just out at the McGowan Institute, and it's amazing.
Amazing. I mean, we were doing 365 livers a year. I mean, it was just an exciting time in medical research and practicing, and that is to say, taking that bench and putting it into clinical practice. I worked at the Brigham and Women's Hospital for a number of years, but you just don't get the feel of working in Milford.
If you're doing one a day, every day of the year, and the patient population, I mean, it makes my mother feel so good that when she walks in, it's been the same oncology specialist for the 10 years.
It's remarkable, and Dr. Kadis continues to deliver the kind of high-quality care that your mom got and will and expect
you see
and
it
should
in
get.
Renee, you see it in Jeff Hopkins.
Absolutely.
It's his emergency room.
For certain.
You sit there and say, yes, Frank runs it, and Uncle Phil provides the physicians.
Right.
But if there's any doubt, you talk to Jeff, he feels it. That's his home, that's his responsibility. And again, a lot of it, when you're in trauma, just knowing or feeling you can trust the person. And as an old man, when you're bringing a very sharp knife towards me, I really want to know I can trust you, no matter which part of my body you're aiming it at.
Well, the hospital has put a lot of effort into making certain that the providers are of high quality, have maintained their quality, and you can't substitute having leadership such as Jeff Hopkins in the emergency room or Pat McEnany in the surgery division. We really have a good core of people who have, I think, allowed us to provide the care that Milford deserves, and we continue.
So now
to do
your
that.
practice. How long have you been in Milford?
Well, I actually arrived here in the late '80s, and worked. Actually, I was working in Boston at the time, and then having seen the kind of work that could be done in a place like Milford, then took a practice here. Started with my associate, Dr. Amini. Ali Amini and I have been in practice together since approximately 1988. And we are going, strong as ever, I hope. We are soon to add a 6th gastroenterologist here to Milford, so that's hard to believe that we have, grown.
6 GIs
6
here.
GIs, yeah. We will add a new young woman to our practice in July. We're very excited to, be able to expand our service to the community, and we continue to have a wonderful unit to work in at the hospital. We've partnered with them, and that is to say, we do all of our cases there so that people are, when they have endoscopic procedures with our group, they're in a hospital setting. We feel very comfortable with that. The hospital has been a great partner, and I think the services
there. It's our
there.
hospital.
It's ours.
Frank yells at me when I still call it the Little Milford Hospital, because I still grew up with the little red Milford Hospital where I was born,
Right.
And now I look out there and it's like, it's not. It feels like the Little Milford Hospital, but it looks like and it offers services that rival anything in town.
Well, we think you can get we know what we can do, and we try to do it well. And what we want to do is be connected to places that, can provide the service that we don't do, and nor should we do. And so that
There's always
makes
going to be
it very,
those extremely specialized cases.
and that's the way it should be.
And that's what the teaching hospitals have always been great at.
That's right, and that kind of affiliation and cooperation between those kinds of institutions have made us what we are and them what they
There's
are.
nothing against man's greatest hospital. MGH. You go in there, they let you know, and I'm glad they feel that MGH stands for not Mass General, but man's greatest hospital.
Absolutely.
But it doesn't feel like my little hospital.
No, well, you won't. I think the nursing care that is provided, the kind of dedication to the community has been outstanding.
Donna and the whole staff there, you just feel this pride they have in what's been built.
Yes, they are very loyal, and most of our staff have stayed on, and I think it's one of those mutual respect things. I think our administration respects them.
When would somebody? Most people can't spell your specialty. Hence GI always seems safe.
Yes.
But I don't wake up in the morning and say, I want to go see a GI. When would I come to you?
Well, I think in most cases, people are referred by their primary doctors when, after having conferred with them, there are certain illnesses that need further investigation. And let's just sort of drift towards inflammatory bowel diseases, in particular Crohn's, which is one of the things that is not, let's put it this way, it's not uncommon. I wouldn't call it the most common disease, but those who have
It's not understood.
Unfortunately, despite the fact of our medical and research expertise, it's that the cause is still not really known. It's, you know, it has a lot of manifestations, but the cause of that illness, you know, seems to be some sort of infection that it triggers an immune response that then continues.
And the immune response doesn't go away.
Doesn't go away.
It's like an eternal...
Yes, an unchecked immune response. Now, no one's ever found the infection. No one knows exactly why the inflammatory response persists or why it does some of the manifestations it has. Fortunately, because you sort of know what it's doing, you can find medications to both reduce that inflammation as well as alter the course of the disease, and that has been
But you can treat it. We don't know of, from what I understand, we don't know of any cure.
No, but fortunately, many people do get to go into remission from the disease, and you know, having been here since '88, I have a lot of patients who we're just sort of, you know, keeping an eye on things, trying to manage their disease. Hopefully, we're making an impact by sort of prolonging that remission and trying to block some of the potential complications, including malignancies that can occur in the setting of inflammatory bowel disease. As you probably know, the Crohn's and its sister or brother, depending on how you look at it, ulcerative colitis, both carry with them an increased risk of certain cancers, particularly colon cancer.
But Dr. Kamali, let's take a step back. How do you know? How do I know I have Crohn's? What are the visible symptoms or effects?
Yeah, sort of the classic presentation is that of abdominal pain, frequently diarrhea, not always, but frequently diarrhea. And that can be due to malabsorption because a certain area of the intestine has been affected to the extent that it no longer absorbs the things that you would like it to absorb, which then induce diarrhea. Or if the disease affects the colon, it interferes with the water reabsorption that our colon's job is to do. You know, the colon is not that sophisticated. It takes that all of the materials that we have not utilized, and essentially its job is storage and restoration of the fluid. It presented to it totally liquid, and then it just pumps out the water. It's an incredible water conservation device.
It's kind of the body's sump pump.
You betcha, and it works really good.
When it works.
Sometimes too well for those who experience problems with bowel evacuation and constipation, where you know, it's just hard to keep things soft enough so that it can transit the colon in a reasonable fashion so they don't feel uncomfortable. But the classic is to get patients in with crampy abdominal pain, diarrhea. Sometimes it can be very subtle. Crohn's is an amazing disease. I've had patients present to me who their menses stopped, or growth retardation, particularly in younger patients. You know, you get a 14-year-old, all of a sudden they've been following their growth curves, and you know, good pediatricians.
And the percentage just keeps going down.
Yeah, just you know, they're growing and growing, and all of a sudden they hit 15 or 16, and it just flat out stops. And that's when somebody knows that this isn't right, and then you start to look, and sometimes they're clinical manifestations are subtle. I mean, you'll look at a patient and say, gee, they look as healthy as you or I, and yet if you were to do radiographic studies, CAT scans, endoscopic studies, you say, my goodness, you know, this person is really ill. There's a lot of disease here. And yet, there's the other aspect of that spectrum. We have patients coming in and they're just awfully clinically ill. And then you go look and find how much illness is there in the case of this inflammatory process. Gee, it's only one or two little areas. What's the deal here? How come you're so sick? Well, that is part of the conundrum of this disease. It doesn't sort of follow the book.
So when you look at a normal intestine, the length is?
Well, there's the colon itself. That is approximately 6 feet in length. In length. And we're able to look at that very readily with the current endoscopic means. We use video chip technology. We have great scopes. And with the proper sedation, this is not a difficult task for 99% of patients.
You're looking at a pretty lengthy
Yeah, that's
hollow organ.
Yeah, that's only the last 6 feet.
I was going to say, the 6 feet is the end.
The end. The 22 feet is between the stomach and the start of the colon. And to tell you the truth, that's where a lot of Crohn's disease is present. About half of the patients will have disease in both the colon and the small intestine.
But now when you talk about almost 3 yards, you got 30 feet.
Yes.
You know, and it always hit me as if it's a street with a pothole. And the question is, how much of that 30 feet is really affected? Because you can have one pothole, like you said.
That's right.
You know, if you're driving along, the one pothole is statistically insignificant unless you hit it.
Yeah. Well, the interesting thing about Crohn's is that it is notorious for skip lesions. And that is to say there can be a segment that's markedly inflamed, and then you turn the corner, so to speak, and then the next segment is normal, and then you go to another segment that is abnormal again. So a segmental or skip lesion
So you
type
could have
presentation.
just a couple percent of the intestinal tract really affected. This can really be, as I say in a rudimentary form, the potholes in the road.
Yeah, the most common site, of course, is the last portion of the small intestine called the ileum or ileum, and ileitis is the most common site, and that's a very important part of the small intestine. It's where B12 is absorbed, it's where bile acids are absorbed, and these are the things that allow us to absorb fats. They are things that, if not absorbed, present into the colon and present as diarrhea. They kind of act like detergents, and detergents
They just flush everything.
Oh,
I'm not supposed to be here, so they just flush everything.
That's it. And so they're sort of working like soap suds, and that's not a thing you would like to deliver to the colon. So it's sort of like a strategic pothole, if you will. If it's at a very critical juncture, which is the connection between the large and small intestine, that's an area that can have a deleterious impact, and that's the sort of thing that would cause you to lose weight and not absorb your food properly, and certainly can cause what's called fistulization. And that's where this inflammatory process almost sort of tracks out as if a worm was digging a hole, and it will literally track to other organs. It can go to the bladder, to the vagina, it can go to the skin. It's the devil. And you know, again, it's that inflammatory process, that ongoing inflammation that our medications are designed to arrest.
But it's not something like, if I'm going to be a heavy drinker, and you say, well, I really affected my liver. Yes. If I'm going to be a heavy smoker, well, I really affected my lungs. Okay, surprise. You haven't read anything for 80 years.
Right.
But for Crohn's disease.
Yeah, this is not one you've bought.
Yeah, it's not something I did, right?
Yeah, if I get something bad, I'd like to have at least had the fun of getting
exactly.
there. This is not that. Unfortunately, there's the risk factors are, one of which is smoking, actually, at least for severity of disease. Crohn's disease certainly tracks with severity with cigarette smoking, but genetic factors seem to be a high prevalence sort of risk factor. A family member will put you at risk. Interestingly, though, if you look at some statistical studies in terms of a twin, you have an identical twin. I'm talking about two Al Koreas sitting here.
What a scary thought.
The risk, if one has it, is only about 15% that the other has it. And yet that's quite remarkable to me. They are genetically identical. Theoretically, they've grown up in the same environment and been exposed to similar things, and yet it doesn't always track out.
They can't track out exposure to.
That's true.
Or you've been eating bad things.
Right. But you would think that children at 15 have been pretty much exposed to the same sort of thing. And as you know, that Crohn's disease is interesting because it sort of, it starts frequently, sort of like a bimodal sort of onset. There's one between 15 and 25 where you see a lot of young people, and it's always discouraging to me. That should be the most fun time in one's life.
Right.
You know, between 15 and 25 sounds like a good time. And the farther you get away from 15 to 25, it was probably even more fun than it was. And another in their fifth, sixth, and seventh decades. So it sort of hits young people, and they theoretically in this twin studies, you would have thought that they would have been exposed to similar things. I think it's, again, a science like many others that we will just have to keep working at, and people are working extremely hard to come up with it. And they have come up with not so much an etiology and a sort of cause, but boy, the therapies have made a dramatic difference.
So now, once I'm diagnosed with Crohn's, what do I do?
Sure. Well, there are a variety of medications, and there's a lot of different theories on how to approach patients with Crohn's disease. And there's sort of what's called top-down and, sort of bottom-up therapy or step-up therapy, where you start with the most benign of anti-inflammatories and then sort of graduate up. As opposed to starting with the newer biological agents. These are agents that are essentially antibodies directed at certain types of cells which are ongoing inflammatory cells. They're called killer cells or natural killer cells. And you set up an antibody to them, it wipes them out, it knocks out the inflammation. Again, it did not stop the cause, it just wiped out the inflammation. But that wiping out of the inflammation will stop some of those stricturing that occurs secondary to the inflammatory response. The fistulization allows for reabsorption, and people do extremely well with that.
When you talk about fistulization, I get nervous about, you're going to bore a hole in the side of my intestine?
Well, that's what the illness does, and we're, and it's sort of like...
Not that I want what's coming out of my GI tract just floating around.
Yes, it can be quite dramatic, and the interesting thing is it always seeks it's sort of like water going to its lowest level. It wants to get out, and so it goes to a low level, be it the skin, be it an internal organ that's exposed to the outside. So vaginal, colovaginal fistulas, colovesicular, meaning it goes to the bladder. It's a tough illness for those who have fistulizing disease, and about 1/3 of patients with Crohn's will have fistulizing disease. So it's not again.
So there's a therapeutic treatment from the get-go.
Absolutely. There's anti-inflammatories such as what are called mesalamine products. There's a whole bunch of them, all of them very effective, different modalities of delivery to the GI tract. It's an interesting molecule there because if you just gave it to them, they would absorb it in their first portion of the small intestine.
Would it ever get down?
Go in the urine and gone, so you wouldn't get it.
The kidney's going to be your worst enemy there.
Right, so you have to trick it, and you have to capsulize it so it's not released until much later in the GI tract where it's not absorbed, and then allow it to be released. And people have encased it in wax, and they've put micro capsules around it, make it pH
like a
sensitive.
liposomal type treatment.
Exactly, and so you make it pH sensitive, so in the acidic environment it's not protected, and as it heads downstream it starts letting go. So there's a lot of science in terms of delivery, and that's, again, very beneficial science for other diseases. As you want to be able to target any medication to the site of where the activity is.
Is there behavioral modification? I mean,
well, it's sort of like diet and behavior. I don't think either of those things will cure it, but I can tell you this: when I have patients with Crohn's who are under stressful environments, be it school, kids are at college and they're at 22, and let's face it, no matter how smart you are, you had to study like heck, and it causes flares frequently. So stress, to me, again, I can always sort of predict that things are going to be tougher.
But again, you tell somebody, okay, bring the stress level down. Okay, 15-year-old is the first, bracket. Let's say you're going into high school. Yeah. By definition.
Yeah, can't get much more stressful.
I was going to say, by definition, you're under stress.
Right.
Does he like me? Does she like me?
Yeah.
Will I be accepted?
Yes, it's difficult. On the other hand, good nutrition, plenty of rest, and that's something that I really try to stress is good nutrition and rest. These people shouldn't try to burn the candle at both ends. And young people today, particularly, you hear them, they're all taking 15 AP courses and trying their best to get ahead in a very difficult world. Well, they put pressure on themselves. I don't know what you do to tackle them, to slow them down.
I mean, we lived in college on 3 to 4 hours sleep a night.
Absolutely.
And come, the weekend, you got your 8 hours to sort of recharge. I'm sitting here now at my age. If I don't get 5 hours, 6 a night, I'm wiped out.
It's very difficult, and they need more sleep than you do, you know, and in addition to an illness, that is, you know, I liken it to them as I'm sitting here and you're sitting here, but you're running the marathon while you're sitting here because your body is trying to fight off an inflammatory process that is unrelenting 24/7. And, you know, I think they do amazing things, and those that are compliant do wonderfully. We really had great successes with, you know, from medications such as mesalamine through, we try to keep people away from steroids, but sometimes a short course of those can be very beneficial. We have immunomodulators, which are things that blunt the immune response, again, all geared at reducing that inflammatory process. Unfortunately, a lot of people ultimately will require surgery because that area of inflammation has become so inflamed.
When you say surgery, you're going to cut part of my ileum out?
Yes, as a matter of fact.
Last time I looked, I kind of need every inch there.
Yeah, they try to be as conservative as possible, but for those that the disease has progressed, and I am optimistic with these newer medications that are so dramatically effective, that surgery will become less common. But it's not an uncommon event for patients with Crohn's. But I'm very optimistic as I sense less of my patients ultimately require surgery. And I think we've really seen a lot of impact of these more aggressive medications. The question is always, well, who needs the more aggressive medication? I don't want to give a very, you know, high-level medicine for someone whose course may become quite benign. And so there's certain selection factors, and we look at genetics, and we look at their, you know, their smoking habits and the extent of disease and how bad things were when we found it, and try to make a prediction, you know, and it's a guess.
And the whole objective is to get it into remission.
Absolutely, absolutely.
You can't cure it yet, but let's
get it
keep the flares down and let you live as normal of a life as you can.
With all diseases, my goal is that they live with their disease and they live a normal, active life, and they're participating with family members and friends just the way everyone else is, and not let this disease take over their lives. And that would be.
But it's not a disease you can ignore either, because you can roll right into oncology effects.
Yes, with the long term, we do watch them closely as they progress in times. But having said it, if they, you know, are compliant with their medications and, you know, follow certain rules that their family and doctors will tell them, I think they can live long and productive life.
What are the biggest changes in somebody's life?
I think they're, you know, it's first off, it's, you know, you're on medicine. And that means that there's certain requirements. You have to get your labs checked. I mean, you have to make certain there's no adverse impact on the white blood cells, sort of like chemotherapy. Yeah, you got to look at your LFTs and make sure that this isn't hurting your liver, and we need to adjust their medication accordingly, that their white count stays elevated. These medicines are funny sometimes. You take them for years.
You're playing with my immune system.
I understand. It's frustrating in that some patients will have the same medicine for years and years, and then all of a sudden,
bang.
Bang. They can't take that medicine anymore. And, you know, you have to go to a different spectrum. And today we're very fortunate because as these newer medications become available, we can make an impact. And as long as everyone's on the same page and following through, I think we can make them live a long, long life. People don't die of Crohn's. They die of complications of Crohn's, and we can try to prevent those.
But what would I, obviously, knock down the stress? You know, I'm the world's worst poster child of sleep. You know, tonight I got a hockey game at 10. By the time I get home, it's midnight. You unwind, it's 1.
That's right.
You know, so you sit there and say, okay, if I was faced with Crohn's, first thing you'd tell me is, I'm sorry, you're not playing hockey with 18-year-olds anymore.
Yeah, it would be difficult. So let's put it this way. I never restrict anyone. I always try to, again, make sure they are doing everything they need to do to keep them healthy. But I wouldn't want to take away someone's ice time.
Right.
You know?
Got to do something.
That would be the last thing on my agenda.
But I mean, from a normal everyday, Are there certain foods that you now recommend against, or?
Interestingly, there's certain things that sometimes are difficult for people to use, particularly if they become stricturing disease. In other words, the bowel has become inflamed and it's narrowed down. So the things that we typically like to use, like high fiber foods, frequently are not as acceptable.
That's it could exacerbate the problem.
Yes, because because it's non-digestible, it can become obstructed in areas of stenosis or narrowing. I would prefer that they, on those patients, try to use a little bit more low residue, even though my other patients, I'm telling them to take fiber.
Well, here we go. You got a fat old man that's being told lose weight, eat fiber, eat this, and you sit there and say, yeah, I'm going to clog everything.
Yes, and those people do have to make those dietary alterations. Certain people have found that certain things help them more than others. There are trigger foods to exacerbations of Crohn's, and some of them are almost unique for them, but there is a list which we can help with them. But we try to, culture their diet or sort of direct their diet towards one that will give them the nutrition they need. Again, sort of like the analogy of running the marathon. They need their calories, and they really do need to pay attention to their nutritional health.
But most important, what you said to me that was profound is people don't need to die from Crohn's.
No, they don't. They don't.
You have to alter. You have,
Yes.
It's things you'll change to make sure that the secondary effects don't get you.
Right. Well, again, in this new era of internet availability, the Crohn's and Colitis Foundation has a wonderful website that can really guide patients not only to share experiences with other patients who are, have the same malady, but give them the knowledge base. And diet is a big one on that site, and they talk about that. In other words, there's no diet's going to cure you. Maybe you're one that if you restrict gluten, that'll help. A lot of them are lactose intolerant, and we don't want anything that confuses them. They're going, oh, every time they get a bellyache, it's my Crohn's is flaring. Well, maybe not.
Maybe it's the Szechuan you ate and everything else, that just in general.
Or a secondary infection, or they had a recent, earache and somebody had to give them antibiotics and they ended up with an antibiotic-associated diarrhea. And we're always trying to first make sure that there's not an infection or a secondary cause before we start saying, okay, we got to bring out the big guns here and do it. So it's something you get an opportunity to work with people, and if they're patient with you and you can be diligent, it's really a gratifying.
But Crohn's isn't the only IBD.
No, its brother, of course, is ulcerative colitis. Ulcerative colitis has the benefit of only affecting the colon, whereas Crohn's can affect your mouth down to the rectum.
Yeah, you got 3 feet that Crohn's can take advantage of.
It can take advantage of anything it wants.
3 yards, 30 feet.
It takes the whole 30. You can affect the stomach. It's rare to affect the stomach, the small intestine, upstream as well as downstream, and as well as the colon. Whereas ulcerative colitis
is the last 6 feet.
Is the last 6 feet. It tends to be restricted to the mucosal surfaces. It doesn't do as much it doesn't fistulize the way Crohn's does. It can cause perianal disease and inflammation, but not that fistulization aspect that we talked of earlier. And as much as we don't like to talk about it, if you were to remove the colon in a patient with ulcerative colitis, you've cured them. It's a big price to pay, and not one.
Wait a minute, can I take a step back here? That's got to be kind of, death is door C.
Yeah.
Door B, losing a colon.
It's not something we would like to see, and ulcerative colitis can have extracolonic manifestations. It can affect your liver, it can affect your eyes, and all these other areas. But the big one is the liver that you worry about in the setting of ulcerative colitis. But the gastrointestinal manifestations, the diarrhea, some of the issues thereof, they can actually be cured by removing the colon. We try not to do it. We're always concerned because ulcerative colitis does carry an increased risk of colon cancer, and we want to save patients. We don't want to save colons.
Well, again, we don't want to go to door C. Death is not a good alternative, no matter what.
Option. It's not part of the oath.
Right.
But But having said that, again, I think the newer medications, which are very similar between the two diseases, have made an impact, and the number of times I've seen patients require colectomy is decreasing rapidly.
And again, I'll take a bag before I go to door C.
Right.
But what percentage of people actually lose their colon?
Well, it's not high. That's the good news. You know, it's really a low number, and in our practice, I certainly have not seen anyone have to go for total colectomy for quite a number of years, indicating that patients are coming and getting medical care. Maybe it's insurance issues that now allow that to take place, but that the medications can rescue them, and we really work diligently. So it's not a common occurrence. It's been great.
And if we move up, like esophageal issues,
Sure.
what percentage of your patients are you dealing with on that?
Well, in terms of Crohn's, it would be extremely low. That's, you know, I've seen 1 or 2 cases in my career of Crohn's involving the esophagus. Stomach, not as uncommon, but the esophagus less commonly. On the other hand, there are a lot of disorders of the esophagus that, as a general gastroenterologist, we would, you know, be sort of involved in. I think people have very unusual diseases, from motor disorders of the esophagus, where the esophagus just doesn't work the way it ought to. And the esophagus is as dumb as it might seem, is just a tube connecting our mouth to our stomach.
But that
Quite
feels
dramatic.
more like a trachea.
Yeah, but
You
it's
know,
not.
when you look at a trachea,
Yes.
or I just spent a week in London, a trachea.
Yes,
I had to get
yes.
used to that.
Yes,
but
absolutely.
when you look at a trachea, it is a tube.
That is basically a tube, but this one's a much more dynamic tube.
This tube is working.
Yes, it's a
It's
working
not
tube.
we call it a hollow organ.
Yes.
You know, when I think of solid organs, I think
Sure.
kidney,
Livers.
heart, you know. An esophagus has got to work for a living.
Well, absolutely. I mean, the coordination that goes on when we swallow is quite dramatic. I mean, for every time we swallow, be it the cup of coffee that you're drinking or saliva, it's going to trigger the simultaneous relaxation of the lower esophageal sphincter, the barrier between our stomach and our esophagus, and at that very instant, it's going to instigate a peristaltic wave that's going to start at the top and work its way down.
All the way down.
It's like a wave at the beach, and it's going to push it right down into the stomach. And that coordination, so the valve at the bottom has to wait until that wave of contraction gets there, and then once it passes, there is actually a hyperperistaltic contraction of that lower sphincter to keep everything down in
no
there.
coming back. This is one-way street.
That's the plan. Even though most of us, you know, with either caffeinated beverages, which relax the sphincter, or spicy foods, etc.
Dr. C, alkaloids are my friend.
Yeah, apparently.
Alkaloids are my friend. You can see from my coffee,
Yeah.
I like alkaloids.
Yeah, so it's, well, you know, there certainly have some benefits. Coffee has been documented to be very good for your liver. So, you know, I'll give you that one anyway. But having said that, these are the esophagus itself, you know, and I think we see its dynamic nature when we try to alter it, such as putting in a stent for those who have strictures or malignancies of the esophagus that occur. And you can see the difficulty in managing those patients who don't have that dynamic function.
Now, when you talk about stenting an esophagus, why? Is it trauma? Is it...
Yeah. More commonly, it's due to malignancy, be it an active malignancy that's under treatment, that you need to keep it open. Now, you can bypass it at times by giving a feeding tube, but if the esophagus itself is closed to the extent that they can't handle their secretions, it's a tough way to go because you're not able to even handle that. But it's something to keep this lumen open. So very similar, they have wire mesh devices similar to the trachea itself, and you place them in there, you secure them in place, and it allows a conduit for food to be delivered directly into the stomach.
You're losing the peristaltic action.
You got
aren't
it,
you?
and that's where the rub is, that things can become obstruction.
The more you stent,
the harder it is to work. yeah, it don't work that hard. But having said that, important times require,
Again, door C. I
you
don't
gotta-
like door C.
You have to do what you have to do, and we're fortunate to have them. And, we have them in the colon, we have them there. The biliary tree is stented very frequently, so keeping the bile ducts open by using, metal or plastic stents has been extremely good technology. We have a lot of engineers to thank for their hard work in allowing us to put those things in place and having the technology to do it.
Now, you hear about reflux. Now, if my little valve is working and I get my hyperactivity at the last second, how can it go back?
Well, because there's inappropriate relaxation, unfortunately. Sometimes it's due to, the foods we are eating, the intragastric pressures, perhaps the delay in stomach emptying, which promotes this. There are so many mechanisms involved in the esophageal clearance. Even the production of saliva, its bicarbonate content, neutralizing the acidity that comes back up into the esophagus. All of those factors are sort of combine to keep ourselves from having erosions and inflammation of the esophagus. Some of it's our dietary habits. If you tend to work late, you tend to eat late. You eat late, and then you finally can, become recumbent. And when that happens, the stuff hasn't emptied yet, and then it's coming back at you. And that can cause long-term damages. And some of those damages can actually put us at risk for esophageal cancers. Certain of our other habits, cigarette smoking, alcohol use, seem to be tracked to an increased risk of those.
But now, when you think of food, everybody says, well, I ate some really spicy food, and it's coming back on me. Myth or fact?
Oh, it's a fact. I think we've all experienced it, and it's my sort of advice to patients is you have to decide what you want to pay the price for here, and many of them would like to pay the price because they enjoy those foods, and our job is to make it so they can.
There's something about wasabi and having my sushi, and I put way too much wasabi, and that eventually the titer's going to build to where wham, it's like one of those, what is it called, ice cream headaches when you were a kid?
Yes, of course.
That you knew you were eating too much ice cream too quickly?
Yes.
And sure enough.
And this will do the same. And you pay, but again, with great medications and acid reduction and some, common sense, we can get through many esophageal disorders.
When you say acid reduction, I've got a stomach that's producing pH 3, 3.5.
Even lower, but,
Because it's supposed to.
That's correct.
How do I reduce that without affecting its ability to process?
Yeah. Well, we certainly have medication that is very effective at acid reduction. There are pumps that are making acid, and we have medications that actually bind those pumps and prevent the acid production. What has been interesting is the fact that despite the fact that we can shut down that acid quite effectively, it hasn't seemed to dramatically increase the infection rate. You'd think that you're getting some sterilization of our food as it passes through an acidic environment, but it doesn't seem to be, we don't see that many more, say, gastroenteritis infections in patients on those medicines.
It's amazing, because when you think about something like Coca-Cola, you're putting enough phosphoric acid in there to get it to pH 3.5.
Yes. All by itself.
Compared to the stomach, that's not incredibly strong as an acid.
No, it isn't.
But yet, you can sit a Coke can out for a long time before anything's going to dare grow in it.
That's right. And yet, neutralizing that acid has not translated into a marked increase in infection rates. There may be some. There may be some increased risks of pneumonias, of reflux, because now people reflux and aspirate, and therefore it hasn't been acidified, and therefore perhaps there's some increase there. There's some infections of the gastrointestinal tract.
Is it that it's going to come up and go down the trachea? Or?
Yeah, it will. If you aspirate, it'll frequently go into the right main stem, so the right-sided pneumonia.
That's when you start coughing, saying it went down the wrong pipe.
And it did.
And it did. It's as simple as it sounds.
Right, and certainly if you have reflux or a relaxed valve, either due to a hiatus hernia where the opening has now become persistently relaxed, things can reflux back up, and particularly if you're at sleep, you're not as attentive as you would be awake typically, and therefore you cannot protect your airway in the same manner. So again, good anti-reflux measures, sometimes raising the head of the bed, not eating before bedtime, keeping that acidity low if it's possible, to allow the sphincter to close because it really doesn't like being in that acidic environment. All of those things will impact this. Well, I don't know.
You're dipping your finger into, a strong acid.
Right. Well, again, we have a lot of late night activities, and some people take ice time from 10 to 12, and then when they're on their way home, they may get a drink, and and I don't mean an alcoholic beverage, anything, and then it sloshes back up on them, and so you have to be careful.
Now, when you talk about esophageal issues, obviously the inflammation, the stenting, how often do you run into esophageal cancer?
Unfortunately, that's a tough cancer, and we do run into it with a fairly frequent basis. I mean, there's going to be, 10 or 12 cases a year that have passed through us, and they are hard cases because the esophageal wall.
What makes it so hard to treat?
Because it typically has spread prior to the diagnosis. Colon cancers, there seems to be a predilection for this thing to sort of stay in the wall or
it's very provincial. It stays in its little space.
In a lot of the cases, you can make a big impact just by surgically removing it. In the esophagus, you have to be very lucky to have caught this early, to have prevented spread of the disease. And it's a real hard one to treat. We have wonderful modalities, radiation therapy, chemotherapy is making a big impact, but it's still a tough diagnosis for patients, and we want to see much more progress than we've been able to make in terms of the medical care. But when we have players such as at the Farber and Dr. Kadis who are very, up on the latest of it, I am always optimistic for our patients that they can do well with this. Again, it's part of living with diseases. It's sort of like living with Crohn's. We want them to live with their other diseases.
Intestine, when they diagnosed my mom, they said they're going to cut a section out and resect it. Okay, I've got a few feet there.
Yes.
You're going to take a pothole out.
Right.
Okay, you're going to take a few inches out. But in an esophagus, a few inches?
Yeah, they will use, what they'll do is bring the stomach up to there, and so it's called a gastric pull-through. It's a difficult operation technically, and it's a difficult operation for patients afterwards. But again, now we do a lot of radiation ahead of time, we do a lot of chemotherapy ahead of time, trying to salvage as much as possible so that when we do the operation, we're finalizing the deal and hopefully get a good long-term outcome. Not an easy one, but one I don't think patients should be in despair. I think it's something to be optimistic about at all times.
Well, it seems like many of the indications that we face, the key is constant monitoring and catching them early.
Yes, we do a lot of surveillance because there is a predisposing factor to esophageal cancers, at least in some cases, called Barrett esophagus. And that's for patients who have had chronic reflux, where there has been actually a change in the esophageal lining. Instead of being this squamous lining, which is the typical skin-type lining, it becomes more like the stomach lining, and it becomes what's called columnar lining. And that's ectopic
Why
mucosa.
would you not expect it? Let's see, you're bathing, if I think about the stomach lining.
Yes, the stomach's doing what it should do.
I'm holding a vat of pretty concentrated acid. You think of your chemistry days. Anything below 2.5, boy, you treated that with respect.
That's right.
So I've got essentially a vessel to hold very strong acid. And I'm going to take some of that and splash it up and down.
Constantly.
The esophageal space.
Right. What's your body going to do? It's going to try to protect itself.
It's going to protect itself just like the stomach does.
That's right. And it's going to send some of those cells up there to line the esophagus, at least that's the theory. And unfortunately, that's ectopic mucosa. That's mucosa in a position it shouldn't be. And for reasons that aren't 100% clear, that does increase its risk of conversion to a malignant growth. And we monitor for it. There are new techniques to try to obliterate it, so they're very exciting. Radio frequency obliteration, RFA, for certain patients is a good idea, and we're starting to feel more comfortable with it. Initially, there were a lot of problems with stricturing, et cetera, with the technique, but now I think, again, like everything else, our engineers have really worked with us
Well, I think people, as they start to look at esophageal issues, as opposed to tracheal issues, you start getting a respect.
That's right.
You know, we've done in the world now 10 synthetic tracheal transplants. Nobody's done an esophageal transplant. Why? Because it's not just tube. I hate to call it a lazy tube. This is a working
It's a dynamic
organ.
process.
This really feels like an organ to me.
Right. Well, with the stem cell, availability and the adaptability of tissues in the body, I don't think we should lose hope that someday we will get to that point.
I mean, when I see the work being done, by your fellow mudfuds, the MD,
Yes.
PhDs who've dedicated half their working life to education down at NIH, or we were just at University College in London, where they've got a very active program on the study of esophagus and coming up with synthetic alternatives. It's like you think about 30 years ago when somebody said a heart transplant, and that was Star Trek. That was
right.
Beam Me Up.
Well, as you know, I mean, the availability of these and organ preservation and having organs, or at least artificial means of maintaining people, be it with kidney dialysis, which has really helped a lot of people as a bridge to transplantation.
Staying out of door C. Yes, door B is not pleasant.
At all costs.
But it beats door C. Well, thank you for coming on and helping us to understand. And maybe a few of the people of the 6 who watch have Googled and now can spell the GI. But we are very, very fortunate when you think about what has been brought to our little town here at the center of the universe. You can get care that only a few decades ago, I mean, I joke about being born in the little red Milford hospital. But when I look at what Uncle Frank and Uncle Phil have brought to this town, it's pretty amazing. And I have experienced it firsthand in the effect on my family of being able to stay in our little town and deal with physicians as yourself who've been here many decades. So for that, we thank you.
Thank you.
And as always, have a good night. May God bless. Let's hope that you never have to learn firsthand about a lot of these indications, but you can feel comfortable that should you or any of the family members you value so highly have to deal with them, the service is here in Milford. So for that, we thank the entire medical staff. And to the 6 or 8 people who loyally watched, thank you, good night, have a good day. May tomorrow be a healthier day than today.